Record. So now that we're recording, let me introduce myself very briefly again. Jesse Suter, he, him pronouns. I am the director of the Center on Disability and Community Inclusion, one of the hosts today. And I'm a white man in my upper 40s with no hair, a light colored button-up shirt, and standing in front of a green virtual background that has our logo, and then also the website go.uvm.edu/scopevt. I'm going to turn it over to one of the co-hosts to introduce our main presenter today.
All right, good afternoon. This is Michelle Shepard, and I also use she, her pronouns. I'm here with Project Scope as well as the VCHIP Icon team. I am a middle-aged woman with short hair, and I am wearing a green shirt in front of the same background as Jesse. And I have the pleasure of introducing again Dr. Andre Jones, who we are so excited to present this afternoon. Dr. Jones is the executive director of UNC Horizons. She's also professor in the Department of Obstetrics and Gynecology at the School of Medicine, the University of North Carolina at Chapel Hill. She also has joint appointments in the Department of Psychology and professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University. We have many, many things we could say, and I'm going to keep it brief, but just know that Dr. Jones is a licensed psychologist and is recognized internationally around her work in the behavioral and medication treatments for pregnant women and their children who are affected by substance use disorders. She is world renowned for her expertise around neonatal abstinence syndrome and opioid-related disorders. She has written many, many, many publications, more than 200, has continuous NIH funding since 1994, has written books and chapters and international guidelines for the WHO, as well as for SAMHSA and the American Society of Addiction Medicine. She also is in the section of Women and Children's at the United Nations International Standards for the Treatment of Drug Use Disorders and guidelines around prevention and treatment for girls and women. Many, many, many awards have been won, and most recently, Dr. Jones received the 2020 American Society for Addiction Medicine R. Brinkley Smithers and Distinguished Scientist Award. So with so much expertise and so many, many years of experience to share with us, I do want to turn it over to Dr. Jones to share with us this afternoon.
Thank you, Michelle. I so appreciate the lovely introduction again. And thank you to the University of Vermont and the VCHIP program, as well as the Vermont Department of Health for having me. And I'm excited to be able to join in this conversation this afternoon. If you could advance this, Jesse, if you could, next slide. Thank you. So with the time that I have, we'll take a little look at the Horizons model of care, which is a comprehensive care program that helps support families. We're going to also look at least one advocacy strategy, hopefully, that you can come up with, and I think maybe a few more, to support change in your region, and then look at the collaborations that have been effective in Horizons. So for you to think about how that might apply to your community and your region. Next slide, please. So here we have the Horizons model, and I think it's helpful to talk about the Horizons model through the experience of one of our women. And so this is Amanda. Amanda came to us as, and I just realized I forgot to introduce myself in terms of she, her pronouns. I am a middle-aged white woman with blondish brown hair, blue eyes, glasses, and I am in front of a grayish background. So I apologize I didn't do that in the beginning. Horizons, this is Amanda. Amanda came to us from an incarcerated setting. She was actually in prison and was pregnant with this adorable little baby that you can see there that is doing some self-soothing techniques in this picture. And she was already parenting the other beautiful little girl that is on the other side of her. And when she came to us, she came directly from prison. She had absolutely nothing, but she was fortunate enough to be able to be released into basically our custody with her child, because the prison system actually trusted Horizons to be able to care for her and her child and to deliver her baby safely. And so when Amanda arrived, she went into our residential program. We have two. One is called Daybreak, the other is called Sunrise. And Amanda received a case manager who is going to help her throughout her stay. She can stay, she stays about an average of 9 months, but you can stay up to 12 months, depending on if you're this close to getting more permanent housing or there's some other type of extenuating circumstance. So we use the ASAM criteria to move her through her treatment. And so it really depends on how she's responding as to what dose of treatment that she's going to get. She also received an individual therapist. And so in terms of her substance use disorder treatment, she's going to be attending group treatment. We use 12 different evidence-based practices in the group and individual therapy that we provide, things like motivational interviewing, cognitive behavioral therapy, dialectical behavioral therapy skills. There's a number of parenting programs that we use. So we do group programming, which I'll bounce down to the light purple circle or oval, I guess, where Amanda received early parenting education. Her child in our 5-star Child Development Center was screened and assessed for any type of physical, emotional, cognitive issues that she might be having, and then could receive those services that she very much needed. We also do early intervention services, and even prenatally, our maternal child therapist goes into Amanda's home at the apartment that we rent for her, so she does not have the stress of paying for housing or other types of bills. And Yvette Horton, who's our maternal child therapist, is working with mom, with the older child, and also going ahead and working on attachment even prenatally, so that when baby is born, that we're already off on the right developmental foot. Amanda, with her case management, really wanted to be able to be employed. She had a number of different skills, but had not completed an associate's degree. And so in her treatment plan, she really wanted to complete that associate's degree. So we hooked her up with vocational rehabilitation, which was able to get her scholarships so that she could go to school online and finish her degree. We also have a retired judge who is a volunteer for us, and he helped her with a really sticky parenting or sticky custody issue with the older child. And then the case manager also worked closely with Section 8 housing and the other supports in our area to get her a voucher so that when she was leaving Horizons, she would have a safe place to live. And in the meantime, she got a just now job working at a local grocery store after she completed the intensive part of our group treatment. The other things that Amanda received while she was with us is integrated obstetrics gynecological care. So she came to see us every 2 weeks throughout her pregnancy and through the completion of the 4th trimester, which is that 12-week period after you deliver a baby. And when she was there in our prenatal postpartum care, she was going to see a provider as well as the outpatient case manager and outpatient therapist. She also would see these same people in groups that she received during her treatment with us. So she was already very familiar with them, and they were familiar with her. Finally, because she had been using opiates intravenously, she also received buprenorphine in order to treat her opioid use disorder. And transportation, so we provide transportation to and from childcare, and as well as to and from the residential treatment program to the outpatient center. Today, I can tell you that Amanda is living a very full life. She completed her associate's degree, is now a manager of the grocery store that she was employed by. And what she talks about her recovery, she says that recovery allowed her to be the parent that she wanted to be, and that what recovery looks like for her is living in an apartment that she pays for herself, being a loving, dedicated, and present parent, not just physically present, but emotionally present too, and living a life in service to others to give back to the community. Next slide, please. So these are some of the cross area business collaboration. So Horizons, we cannot do anything in isolation. We are incredibly fortunate to have a whole host of community partners. I promise you, not all of them are on the slide, but we have care coordination for children so that every child in the state of North Carolina that is born and identified as having prenatal substance exposure is referred to CC4C. It's how we do our plan of safe care. We have the Compass Center that is an interpersonal violence center. We have family reading partners that comes and visits on Saturdays, as well as other days during the week for group from our parenting groups. We have a home nurse visiting, obviously the developmental services. So the older child who was screened and assessed, those services that she needed, they came right to our child care center. It wasn't that the child had to go to them. We are really happy to be working with the FIT program, which has a whole host of primary care and other services for people that have been incarcerated and are now out. Hope Renovations, not something that Amanda participated in, but it is an educational, like a vocational program that allows people who have completed, women who have completed substance use disorder treatment to learn how to become contractors, to be builders, to learn plumbing, electricity, so that they can really make a good living wage for what they're doing. And then you can see a whole host of other things. Porch is a food service. We work with drug courts. We work with Oxford Houses, which is recovery housing, faith-based organizations, and Wheels for Hope is a really great one because will provide free cars to women who complete a substance use disorder treatment and can get insurance. So what are the keys to collaborating? Being super clear on who our point person is, being super clear about our boundaries, what we can and cannot share, coming up with two-way releases of information so that the participant knows what we are sharing and with whom we are sharing it, and the reverse. And making sure that we keep in contact with our many partners so that there's good communication. So when issues come up, and of course they come up, that we already have a good foundation of trust in order to have those more difficult conversations. And then I think the other thing too is not something our system pays for, but something we have chosen to invest in, which is time. It takes time that is not always reimbursed to be able to work with these different partners to support our women, but when we can, families, and when we can do that, it actually saves us time and money and expense in the long run. The final thing I would say, and this is pandemic certainly made this much more challenging, but having conversations are best in person. Phone is next, text and email are really our last resort. And I would put virtual somewhere in between person and phone. Next slide. So these are some of our outcomes for our comprehensive care program. We serve about 200 women a year, or birthing people a year who identify as women. That's one of the criteria that the state has mandated, that people have to identify as women to receive our services. And what you can see here is that the Horizons program, so 50% of our women are pregnant, 50% are parenting. So of those women that come to us when they're pregnant, like Amanda, only 5% of the babies are born premature or of low birth weight, which is certainly much better than an untreated comparison condition that you can see here, and visually better than the North Carolina state general population average for prematurity or low birth weight. So we're really proud of our outcomes, and especially in light of the fact that so many of our women, over 80% of our women, smoke cigarettes during pregnancy or smoke something during pregnancy that is a tobacco product, and have a myriad of other challenges that could get in the way of them having really healthy pregnancies and birth outcomes. Next slide. And I think as the next slide comes up, one of the keys to that is that we work really hard to meet women where they are in their life. So what's most important to us is that they keep coming back for their prenatal care and postpartum care. And the sort of traditional standard of drug abstinence is much lesser. Obviously, that is a goal, or a reduction in use, a cessation in use is a goal, but we are not going to withdraw services from someone just because they're not able to establish that. Other outcomes that we have that we're really proud of are the fact that when women have left us, 100% of them are drug-free when they leave the residential treatment. We have 95% of our completers have been reunited with their children, which means that protective service cases are closed. Families are reunited because they've done the hard work to show that they can parent competently and safely. And pre-pandemic, 77% of our women were employed when they left our residential services. That dropped to about 55% during the pandemic. And now we're back up to 80% of our women last year were able to be employed with all of the changes that happened in the workforce. And the other really exciting thing too is that all of them right now have living wage paid jobs. Next slide. We have a model for prenatal care if you're interested in learning more about that. Really, it's that integrated care that the nurse practitioner plus the therapist plus the case manager who has that lived experience as a peer support specialist. We make sure that we're really flexible in our appointments. Our appointments may take longer, about 45 minutes. So that means that the days are much longer for our team. So they flex their time in order to kind of make that up. And we do a lot of education and a lot of outreach so that even after a patient has completed her visit, our case manager or therapist will keep in touch with them in between visits. Next slide, please. And so this is an estimate of how much savings we actually save to the state every year based on reductions in neonatal intensive care unit stays, reductions in lengths of stay, reductions in hospitalizations, overdoses, emergency departments. We have a study that we're finishing up in the next year or so that will have a formal publication of our cost savings for our model. Next slide. This is Horizons Around the World. So we've been really fortunate to have a number of places that have taken our model and adapted it. There is no other Horizons like our Horizons model, and there shouldn't be because every place is unique and it needs to tailor the model of care that we provide to your own community to make it work. Next slide, please. And so what's on the horizons for Horizon? We just received funding from the state of North Carolina to do a transitional housing program. So we're going to start out with 4. It's only 4, but it is a pilot program for apartments for women to immediately move into once they have successfully completed treatment and have employment. It'll give them a little bit longer runway in order to get to that self-sufficiency. We also just completed a project with 4 foundation funding, where we had 132 unduplicated women with opioid use disorder, either pregnant or parenting, that we literally met at the door of prison or jail. We've systematically followed them for 6 months, and we have had 0 overdoses. 0 overdoses and 0 fatal overdoses, which was our main outcome. So we're very excited about these data. And it is not rocket science what we're doing. All we're doing is meeting people at the door and ensuring that they are getting care immediately after release and staying with them and accompanying them. We also have 5 apartments that Wake County is now giving us for housing to extend our outcomes for the pregnant and incarcerated prison project. And then, of course, we're completing our systematic evaluation. Next slide. And that is it. So thank you so much for your time and attention. And I hope that some of the things that I shared you'll be able to think about and consider how to adapt in Vermont.
This is Jesse. Thank you so much. And I just put into chat that people should feel free to write questions. We got just under 5 minutes, so no pressure, but we have time.
Julie asked if the 4 apartments are going to be on campus or somewhere else in town. And so that's really great. So our outpatient clinic is about 10 minutes by driving from our residential apartments. And we used to have 2 separate programs in 2 different apartment complexes, and we recently were able to consolidate because of the exception to the licensure, the IMD rule. So now we can have more than 16 apartments together, which is great because it's just an economy of scale that helps us save money and provide more service. But we talked a lot about where those 4 apartments should go for transitional living. And we decided that they should be in a different complex. This was a team decision because we really wanted to denote the end or the completion of treatment and the moving to a new beginning for that transitional housing. And so because they're not licensed, it'll be much less monitored, which by that stage in treatment, if you've successfully completed, you're doing really well and need us less, but still need us. So there's a case manager that is devoted to that work, who is also a peer support specialist. Nicole asked, is there a specific period of sobriety a mom needs to demonstrate? Oh, no. So we do not have any sobriety demonstration before admissions. In fact, you need to still meet criteria for, it's some kind of substance use in like the last 30 days or 60 days, with the exception, of course, to that would be in a controlled environment. And we look for all signs and symptoms of a substance use disorder. So we know that craving, withdrawal, those types of things, not necessarily just use, is important. And where do we get our funding? Amy, yes. We all need more funding. So our funding comes from SAMHSA. So all states that apply get a block grant that goes for prevention, recovery, and treatment. And within the state of North Carolina, they set aside 10% of the overall block grant for women and children's services. And so we get a portion of that 10%. We technically have 4 different block grant fundings, 4 different grants that come from block grant funding based on the designation. And then we also bill Medicaid for those services that the block grant doesn't cover. So for example, our block grant covers rent and staffing 24 hours, 7 days a week. But then we bill Medicaid for therapy and actually a bundled rate that allows us to bill for case management services, which I know is an active discussion about how that should be paid for. And then let's see, we also have private donations for a whole host of things that are not covered. And then, is there a housing crisis where you practice? Oh goodness, yes. Sarah, I think there's a housing crisis across the United States, but certainly in Chapel Hill. I've watched more apartments go up and apartments become, like, literally there's more housing and it's less affordable than ever. And I think as a country, we need to be talking about the housing crisis that we have with structural laws being changed and administered, but that's a whole nother talk for another day. But yes, we have a major challenge. And one of the things that's really important to us is working with CASA, which is an affordable housing nonprofit, as well as working with Self-Help, which is a credit union. And so finding those public-private partnerships can really be helpful. One of the other things that I didn't say, and I'll end with this, is that we have just gotten a $3 million grant from the Oak Foundation to be able to basically buy our own apartment building. It's being built for us. That will be a combination of treatment apartments as well as 16 transitional apartments. So we're hoping that we can take those 4 and kind of leverage that with the data and outcomes. Thank you.
So we've got one more question was just posted into chat, and I would say, why don't you go ahead and take it?
Okay, all right. So Ellie, thank you for asking, do any of your programs include prevention beyond treatment, recovery, and support? Yes, I guess it depends on how you want to define prevention. In terms of the children, from prevention in terms of not initiating substance use, absolutely. We work a lot with the children and with the parents. And then in terms of prevention, in terms of return to use prevention, we do a lot of that too. in terms of giving skills and other kind of information and knowledge. We also work with other prevention organizations around our community to support different forms of prevention.
Great. Well, thank you. And thank you everyone for your questions. We were just seconds over time, which is why I wanted to let that last one. And also, because it's a great segue. Ali, you are the host of the panel discussion that's about to start. So let me put up the introduction screen. And my goal is to get out of the way as quickly as possible. But I do just want to say thank you to you and to the Building Brave Futures team for organizing this panel discussion, and want to just give it a little bit of context within the Scope Vermont Learning Series, and then I'll hand it over to you, which is this again, and I've said it a few times, this is the final session of the Scope Vermont Learning Series. And the recommendation from our national partners is that you end with sort of model discussion. So we are just hearing about a new model of care that is from the University of North Carolina. And that was a focus of the ICON conference earlier today. So great to hear that example. And now we've got a panel discussion about some of the things that are going on in Vermont in some regions. So we're going to hear from several panelists related to that. What I want everyone to be listening for is how might these approaches work in your region? So after the panel discussion, there may be time for questions, but we want to make sure that we leave time for folks to come together, hopefully in regional groups. So think about the main regions that you work in and listen to this panel and their experiences with this model of care about how it might be helpful for you in your region. So let me hand it over to you, Ali, and thank you so much for hosting this panel.
Thank you very much. And this is Ali, Regional Manager, Building Brave Futures for Chittenden, Franklin, Grand Isle, and Central Vermont. But I'm here today with amazing, wonderful panelists. We have Liz Mitchell from Howard Center. We have Megan Masterson, yes, from KidSafe Collaborative, as well as Jennifer Flink from Family Services, coordinator at Champlain Valley Office of Economic Services, Head Start. We prepared basically 3 questions to tell you a little bit about the work that we have been doing here over the past 4 years around substance use disorder and trying to support, pregnant women and families. And I was very struck by what the doctor just shared here, Dr. Jones, and specific to, group treatment, about her programs, to childcare, to legal support, and the amazing panelists here will be talking in details about what is happening around those areas right here in this state of Vermont, especially Chittenden and Franklin, Grand Isle. Right. So let me allow the panelists then to introduce themselves. So we can go with Liz first, followed by Megan, and then Jen.
Hi, I am Liz Mitchell. I am the director of the Early Childhood and Family Mental Health Program at Howard Center. We're the designated mental health agency for the county. And I apologize. I actually am recovering from COVID, which I managed to escape for 2.5 years, but apparently let my guard down. So sorry for that.
Hi, everyone. My name is Megan Masterson. I use she, her pronouns. I am a young middle-aged white woman. I have shoulder-length brown hair and a vaguely greenish grayish background behind me. I am the assistant director at KidSafe Collaborative, which is a nonprofit located in Burlington, Vermont, whose mission is to improve community response to child maltreatment.
Hi, everyone. My name is Jen Fink. I am the Family Services Coordinator at Champlain Valley Head Start, which is a program of Champlain Valley Office of Economic Opportunity, or CVOEO. I use she, her pronouns. I have long, brownish, blondish, curly hair, and I'm in my office. Liz, I empathize with you. My youngest is at home with COVID right now, so I came to the office to let her wander around the house freely today. So, and Champlain Valley Head Start is a federally funded program. I see several of my counterparts on the call today, so hopefully they can pinch hit if there's questions that come up around Head Start. And we provide services to pregnant people and families who have children ages birth to 5.
Wonderful. Thank you all very much. And yes, so the first question is, can you maybe describe your project as part of the substance use disorder grant that we received from UVM? And what has been the successes, challenges implementing your project over the past 3 years? Maybe we can start with Megan for this, followed by Jen, and then Liz.
Thanks. So KidSafe Collaborative's part of this grant is that our organization participated in the creation of the new family treatment court docket. And we continue to hold a place on the steering committee for that project. KidSafe's executive director, Sally Borden, is part of the steering committee. Family treatment court docket is an evidence-based model. There's around 400 of them across the country. And it is support for parents whose children are either in state custody or have some other kind of court intervention, such as a conditional custody order. As part of the grant, what we did with that money was to support family treatment court docket participants really in 2 ways. The first is that it is financial support for parents' urgent needs that are a barrier to accessing their treatment. So, for example, the money has gone to a parent who needed a car repair in order to get to treatment, or purchasing gas gift cards for another parent to be able to visit with their children. The other way that the money is used is to purchase incentives, though I sort of hate that word, but it is part of the evidence-based model. So there are items that motivate and support parents' participation in the program. We know that accessing treatment and staying in treatment is really challenging. And so these items are really intended to support parents. There are things like journals, self-care items. We've given parents books, children's books that they take with them when they visit their children. One item that feels really special to me is we purchased teddy bears that had a recording option. And so parents could record a message for their children before giving them the bear. So our involvement sort of day to day with cases is indirect. So we're not, sort of working with these families in a way that you might hear from Jen and Liz in a minute. More so our role is advisory, again, as part of the steering committee. And then that financial support, which is really fundamental in making this project work. As far as successes and challenges, I think you can't be sort of in this day and age without mentioning COVID. That being said, COVID didn't really affect KidSafe. It did more impact kind of staffing for other agencies involved with the project. And of course, we know that the court system has sort of gotten slowed down and backlogged because of COVID, cases having to be kind of stalled. So that was definitely a challenge for us. I would say the other bigger challenge was just that the project sort of ramped up slower than the group originally kind of projected out. And so that resulted in KidSafe sort of spending money a little bit slower than anticipated, which in the grand scheme of things is not the worst challenge to have. as far as successes, I think Family Treatment Court docket has had a significant amount of success despite the slow startup. So we have had parents through the program who have gotten jobs. We've had parents who have started treatment. There are those who have started, a new treatment group or engaged in parent education, which they may not have had they not been part of the treatment court docket. And so I think the success is small but mighty. And the money that we have received through the Building Bright Futures grant has really been critical in making those successes happen for the project, but then also for the families individually.
Excellent. Thank you. Thank you very much. And next, no.
Okay, so I will go next. So at Champlain Valley Head Start, we're actually a little bit newer to the community of practice that came out of this funding opportunity. Although we're 3 years in now, so I can't really say too new. But one of the ironic pieces is that as we were just ready to, we've done the training, we had scheduled all the groups, we had gotten ready to roll, and then COVID hit. So it certainly caused us to kind of change the course in terms of our participation with the grant and our particular activities. So Head Start programs across the country are mandated based on our latest performance standards to offer evidence-based parenting education opportunities to families. And so that is something that kind of is in our world as to what we're supposed to offer. We're also tasked with kind of having some challenging conversations with families about things that may impact their ability to parent young children. And so through those conversations, we may or may not find out about the impacts of substance use and substance use disorder in a family situation. So when thinking about kind of what can we do in our role and in bringing our best selves to this conversation, I really kind of came to it from a place of thinking, we double down on our piece of the pie. We're not substance use clinicians. We are bridges to other services out in the community. And that is based on having trusting relationships, respectful relationships with families, and really kind of helping them feel that they have a space that's not going to judge them. So our piece of the grant, kind of the funding piece of it, is to layer onto our parenting education program, our groups, with some funding that allows us to partner with Liz's program over at Howard for some group facilitation time, as well as offering some additional incentives. I agree with Megan, the word feels odd, but it can be things that are really just helping to address some of the basic needs of life, whether it's food or gas or children's books or parenting books or resources. We helped one parent who was able to, during the course of our groups, talked very much about how dance was an important part of her history growing up, and she was a pregnant mom at the time, so we helped her get enrolled into a prenatal yoga class. And so it's really trying to individualize to each family. So the groups that we offer, we utilize a curriculum, two different curricula actually. One that's called Your Journey Together. It's an evidence-based program out of the Devereaux Center for the Resilient Child, and really focused on attachment and resilience and building resilience for caregivers and children. And the other program, the other curriculum we use is through Growing Great Kids. Again, another attachment-based kind of program. And the philosophy behind that for us is that the relationships are what matter most in terms of how to build kind of their pathways forward. So having good relationships between parents and children, but also having good relationships between adults and their peers and their community and us as providers. Successes, I will say, I had the pleasure last week of taking a couple of parents down to Baltimore for our National Head Start Association conference. And on the way back, we had a long conversation. Both have histories of substance use disorder impacting them and their families. And part of what they really shared is that it's all about the trust, and it's all about the navigating, not feeling fearful that what they share is going to have a negative impact in their success going forward. So that's really kind of what we try to hold as a foundation going forward. So that's kind of on the on the direct service delivery side. What I will say, the other biggest impact for us as a program is just being intentional about building community with other service providers, both with Howard Center, with KidSafe, with Chittenden Clinic, that in Turning Point, and really trying to elevate the topic so that we can continue to do what we do. Our little piece of the pie can be more informed and stronger. I think I'll leave it at that. Liz.
Wonderful. Thank you so much. And Liz?
Okay, thanks everybody. I think a lot of the things that both Jen and Megan said are similar things that I might say, but I think I want to start with the fact that I've been at Howard Center about 20 years, and one of the things that I felt was really missing for many of those years was a real kind of collaboration between the substance abuse world and the children's world in terms of mental health. And part of Howard Center does have substance abuse programming, including the Chittenden Center, which is a medication program for adults. And so we had this goal, I had this goal, some of us had this goal of how does the Chittenden Clinic and the early childhood program better connect? We know we are serving similar families or the same families, but we don't always have access to one another because of confidentiality or because families aren't just telling us that stuff. And so we know that science has taught all of us that the first 5 years of life for a child, that there's such significant brain development. And it really, really does create the foundation for learning and living throughout those children's lives. But that none of that's possible without the primary caregivers and the people that are in that child's life every day. They're their driving force. And so we started to think about how do we focus on our relationship with the Chittenden Clinic, which again is a Howard Center program providing medication-supported treatment to adults. And we were able to identify some people that were champions within the clinic. And this all kind of started at the same time that BBF became involved with the SUD grant and building a community of practice. And so with that funding, we were able to really create a partnership and create an opportunity for parenting / child care play groups within the Chittenden Clinic, and we ended up calling it the Piggyback Project. So the SUD grant enabled us to create a curriculum that was both psychoeducational as well as supportive for parents, and also to create a developmentally appropriate play group setting for children anywhere from birth through 5. That included buying healthy snacks for the kids and the parents, utilizing parent incentives. And when I think about parent incentives, a lot of our focus has been on some self-care things. I think parents in general are always putting their kids first, and self-care is last on their list. And something as simple as a body wash to somebody who nobody would go out and buy something like that, especially can be really significant. And I think those things were important, as well as meeting some of the basic needs. But I think the self-care need was equally important. We also had the opportunity to purchase for families some developmentally appropriate toys that they would be able to share with their children that were really focused on attachment, attunement, and co-regulation of that parent and child. And so, of course, the pandemic then led to really major challenges and changes and adaptation in how we continue to do that. We were able to provide 3 groups at the Chittenden Clinic in the first year and a half, and had probably an average of 6 parents. One of our learning curves is that we thought we'd have way more parents being interested, because we identified times when parents were coming in to dose and could come and bring their kids. But it still is a process. And I think Jen talked about that, building trust. We were a new entity coming in, and even though we had the partners with the Chittenden Clinic, and our group are staffed by early childhood mental health clinicians and Chittenden Center substance use clinicians, it was still a little of a push and pull. But word of mouth started to generate some more interest, and then the pandemic happened, and it really kind of did not allow us to do in-person work for the last year and a half. And unfortunately, I think Megan may have mentioned this too. It also created difficulty within the service world in terms of having enough staffing to even provide the basic services. So we had to pivot, as all of us had to pivot. And we looked at how else we could provide support to that kind of group of families. So initially what we did was, with the Chittenden Clinic, developed a list of families who had children who were either prenatal or up through age 8, and created activity bags for all of those children in each of those families, and then delivered them to those families in the course of a month or so. And again, with the focus on those activities being things that parent and children could appreciate together. We also had one of our behavioral interventionists, who also has her master's degree in play therapy, created some online opportunities for families where they could hear her do some storytelling and some different things with families and kids, so that we kept some connection. The Chittenden Clinic, who really were the people who identified families for us, weren't able to really focus on those groups at that time. And so we were fortunate then to partner with another group in the state, the Rocking Horse groups, which are supported financially by ADAP, but also through Howard Center. And we were able to work with Ruth D'Angelo, who's been a strong supporter and facilitator of Rocking Horse groups in the Chittenden Clinic. And so for the past now year and a half, we were able to infuse the Rocking Horse curriculum with some of the curriculum that we developed for our piggyback group. And we're able to focus a little bit more on the relationship building between children and parents. We focused, Tracy participated particularly in this, and she did some groups on the power of play and how to be playful. That's something adults don't always know how to do really well. And having their kids to do that. We did some coaching with those parents in real life on Zoom, because the groups have continued to be virtual. Although we hope soon that's not going to be the case. And to really practice that. And then Tracy also brought to that group her expertise as an early educator, because many of the parents were exploring the idea of childcare and really looking for some support in what a good childcare looked like. So we fulfilled a lot of roles. Within the last year and a half, we've now done 4 Rocking Horse groups. We just are finishing up the last 2. 3 of them were in in the Chittenden County of Vermont, and 1 was in Franklin County. So I think in general, the successes that we experienced with the help of this grant, which really, I think, fueled us monetarily, but also emotionally to keep pushing, was to decrease some of the boundaries and the silos that were existing within our mental health system between adults and children, and recognize when a family is impacted by substance use disorder, that not only the substance use disorder needs to be addressed, but you need to figure out how you be a parent who's dealing with substance use disorder at the same time, and recognizing that and providing, I think, special places for that to happen with other parents who have similar lived experiences. We saw that there were parents interested, and that word of mouth did a lot of good in supporting the legitimacy of our groups, and we hope to get back to that. We also found that Department of Children and Services became aware of the piggyback groups and actually put that as part of the care plan for some of their families around reunification. And so we had children coming to the clinic, being dropped off by DCF while they were in foster care, reuniting with their moms there, and then participating in the groups. The other piece we learned was about how to be flexible around everything, and which I think also supported the families. And also lastly, I think the power of incentives. And I don't feel too badly using that term, because I really do think that it focuses on how we really just see the self-worth and the importance and the care of all people, regardless of what they're coming with and what they're dealing with. And, the challenges were COVID and remote work and remote groups. However, for some families, those actually worked better. So I think as we move out of this kind of COVID era, I think we're going to probably be more aware of having both kinds of groups available to families. That's it.
Thank you. That's great. So also for the public also to know that we have 2 more partners that are not here today. And one of them is NCIS in Franklin Grand Isle, and they do more about parenting educational programs, as well as they also have like an intensive built-in for families that are participating. We also have childcare resource. They do more tracking about childcare subsidies and also referrals for the people around Chittenden County. So those 2 are not part of here. We have maybe 1 minute, and was just wondering, instead of us talking about the partnership model of care, maybe if people have questions, 1 or 2 in the chat that the panelists can answer. Okay, perfect. All right, so yes, it seems we don't have a question, and it seems also, I just wanted to say that the Black man with a heavy accent from Africa, raising beard in his early 40s, is giving you the floor back. Thank you for having us, and thank you panelists for being here. Good work.